So, how plaques are detected and assessed. Now that we understand that plaque stability matters more than size, the next question is, how can we detect dangerous plaques before they rupture? Fortunately, modern imaging gives us powerful tools, not just to see blockages, but to understand what kind of plaque we're dealing with. The number one imaging tool that we have is the coronary artery calcium score, CAC. This is a non-invasive CT scan that detects calcium buildup in the coronary arteries. A CAC score of 0 is reassuring, but not foolproof. It means no calcified plaques are present, but soft, non-calcified, and potentially unstable plaques could still be lurking under the radar. It's best used as a risk assessment tool, especially in asymptomatic individuals. So briefly, what the numbers of the CAC score means: if you have a score of 0, that means you're low risk, but still not immune to soft plaque risk. If your calcium score is 1 to 99, that means you have mild calcification, generally low to moderate risk, but follow-up and lifestyle optimization are important. If your score is 100 to 399, that's considered moderate calcification, which is significantly higher risk, warrants aggressive risk factor management. If your score is greater than or equal to 400, that means you're having high calcification with a very high risk of coronary event. And that's a strong consideration for intensive medical and lifestyle interventions. The bottom line, a low CAC score doesn't guarantee you're in the clear. Soft plaques don't show up here, and higher scores demand progressively more urgent attention. The second imaging tool that we have is coronary CT angiography. Unlike the calcium score, coronary CT angiography gives a detailed image of the artery walls and the plaque itself. It can show whether the plaque is soft or calcified and identify dangerous signs like positive remodeling, in other words, artery wall bulging, low attenuation, which is a sign of soft, fatty core of the plaque, spotty calcification, and napkin ring sign. This is a high-risk pattern of thin cap fibroadenoma. In this short video, it will be difficult and overwhelming to cover all 4 signs of dangerous plaques in detail. So for now, let's focus on just one, which is the most common to be seen: positive remodeling. Okay, this image is adapted from Motoyama et al. It's a CT coronary angiography and shows a positive remodeled plaque in the left anterior descending artery. The yellow outline marks the vessel wall, and the purple outline marks the blood channel of the lumen. At the plaque site illustrated with the letter P, the vessel wall has expanded outward compared to the nearby healthy reference segment labeled as the letter R, but the lumen is still noticeably narrower, meaning the plaque is large enough to reduce blood flow despite the artery's attempt to compensate. This lesion over here is significant and requires an urgent intervention. Now, let's look at another example, this time of positive remodeling where the narrowing is only about 40%. In this 3D reconstruction on the left, we can see the right coronary artery mapped clearly. The right panel with the yellow arrows highlight a segment that appears only mildly narrowed. If we performed a regular coronary angiography on this patient, the report would likely say non-significant stenosis, no intervention needed. And that's exactly the danger here. Coronary angiography only shows the lumen, the hollow channel where the blood flows. It doesn't show the full thickness of the artery wall. But in this CT angiography, we can clearly see what's hiding beneath that 40% narrowing: a large, deep plaque buried inside the vessel wall. The hallmark of positive remodeling. The artery has expanded outward to accommodate the plaque, keeping the lumen relatively open. This is critical to understand. Even though the narrowing is not significant by angiography standards, the plaque is large, lipid-rich, and inflamed, features that make vulnerable to rupture. If this plaque ruptures, it can suddenly block the artery completely, triggering an acute coronary syndrome. So a 40% lesion here is not benign. It's a high-risk plaque that needs aggressive medical therapy, lifestyle intervention, and close follow-up. A landmark study by Motoyama et al. Published in the Journal of American College of Cardiology in 2009 followed patients with suspected coronary artery disease and found that high-risk plaque features detected by CT coronary angiography, such as positive remodeling, were strong predictors of future coronary events. The second imaging tool is intravascular imaging, IVUS and OCT. These are invasive tests typically done during cardiac catheterization, but they give unmatched detail. Intravascular ultrasound or IVUS provides a cross-sectional view of the artery and plaque burden. Optical coherence tomography or OCT gives microscopic resolution, allowing visualization of fibrous cap thickness, lipid core size, and signs of plaque rupture or erosion. These tools are considered gold standards for understanding plaque composition and guiding interventional decisions. So, to all interventionists, the next time you see a 40-50% non-significant lesion, don't just close up and conclude the story with
medical treatment only.
If you have the tools, use them to assess the plaque's true nature. You might be preventing your patient from a life-threatening event. You will be guiding them to take their health more seriously, knowing they carry a ticking time bomb that could trigger a life-threatening event at any moment. Now, let's say we find a vulnerable plaque during an advanced imaging test like IVUS or OCT. Should we go ahead and do PCI or put in a stent? The short answer is not usually. If that plaque is causing less than 50% narrowing, for example a 40% stenosis, and the patient is stable, guidelines don't recommend stenting. That's because these narrow plaques usually don't limit blood flow, and stenting them hasn't been proven to prevent future heart attacks in stable patients. Instead, the gold standard is aggressive medical therapy, high-intensity statins with other cholesterol-lowering medications like PCSK9 inhibitors, antiplatelets when indicated, strict blood pressure and sugar control, quitting smoking, and most importantly, improving lifestyle habits. Why? Because vulnerable plaques can be stabilized with the right treatment, making them far less likely to rupture. Stenting a non-flow limiting plaque can actually introduce new risks like blood clots or restenosis without clear benefit unless there's objective evidence of ischemia or the patient is in the middle of acute coronary syndrome. So the final takeaway for this section, it's no longer just about how blocked your arteries are. What truly matters is what kind of plaque do you have? Is it soft and vulnerable? Is it inflamed and at risk of rupture? And thanks to God and to modern imaging, we can now answer those questions more accurately and act before disaster strikes. Now, before we move on, we need to address an important question. Why calcified significant plaques often pose less risk? Dense calcified plaques often pose lower risk according to a major study in JAMA. A major study in JAMA Cardiology looked at whether the hardness of a plaque on a CT scan was linked to the chances of having a future heart attack. They measured hardness using a CT scale called Hounsfield units, HU. Plaques with a reading over 1000 HU were considered very dense, also called 1K plaques. The study found that people who went on to have a heart attack were less likely to have these very dense plaques, both when looking at the person overall and at individual plaques. In simple terms, the harder and denser the plaque, the less likely it was to break open and cause a heart attack. Dense calcification is often a sign that the plaque has healed and become more stable. In other words, a higher volume of dense calcified plaque is associated with lower risk of future rupture, making dense calcification a marker of stability. Now, switching gears, what about the choice between stenting or bypass versus medical therapy in patients with stable coronary artery disease? The ischemia trial, a study that many interventionists actually dislike because it challenges the necessity of some of their procedures, is still a landmark piece of research that simply cannot be ignored. The ischemia trial looked at over 5,000 patients with moderate to severe ischemia. They compared an initial invasive strategy, angiography and possible revascularization, versus a conservative strategy, medical therapy with angiography only if needed. Over a median follow-up of 3.2 years, there was no significant difference in death or ischemic cardiovascular events between the two groups. So even significant blockages don't automatically require intervention. If calcified and stable and not causing ischemia, medical therapy is often sufficient. Now, why this matters in understanding plaque stability. Dense calcification in plaques, especially high density, which is greater than 1000 HU, can signal a more stable, less dangerous lesion. Coronary angiography, while important, may not fully capture the risk profile. A lesion that looks severe on imaging might actually be stable and safe. Even a mild 40% narrowing might be high risk if inflamed and lipid-rich. Revascularization should target unstable ischemia-causing lesions, not simply those that look tight. The evidence shows invasive strategies don't automatically yield better outcomes in stable patients, even with significant stenosis. Move, move, move! Hi, I'm Dr. Haitham Faraj, a certified cardiologist. If you want to learn more about what makes plaques stable or unstable and whether lifestyle intervention can help heal them, check out my full video over here. Sorry, I mean here.